Hi, everyone. My name is Gail Roboz. I'm a professor of medicine and director of leukemia program at Weill Cornell Medicine and the New York Presbyterian Hospital in New York City. I wanted to take a few minutes to discuss an important topic in acute myeloid leukemia. We have an exciting change in the management of subtypes of acute myeloid leukemia in using menin inhibitors. And in the United States, we already have two menin inhibitors approved for use. There are several in clinical trials. And I think it's very important as we start incorporating these novel agents into daily use that we discuss some specific toxicities, which may be less familiar to practitioners. Um, and that includes a selection of toxicities that I'm going to go over now. So, just a little bit of a reminder, the menin inhibitors have stormed onto the platform for treatment of patients with NPM1 mutated AML, as well as those with KMT2A rearrangement. So these are molecularly grouped or molecular subtypes of AML that require a specific diagnostic testing at the beginning of the evaluation of the patient. And once these abnormalities have been recognized, there may be consideration either for a commercially available agent or for a clinical trial using menin inhibitors. Now, the first toxicity to know about is something called differentiation syndrome. And certainly oncologists have experience with DS or differentiation syndrome when they think about acute promyelocytic leukemia. So the paradigm for management started with treatment using all-trans retinoic acid or ATRA for APL, and differentiation syndrome became something that was pretty well known, except APL is a rare disease. Now that we have agents also including FLT3 inhibitors, IDH inhibitors, and now the menin inhibitors, DS is something that has to be prominently on one's mind. And basically, it's a little bit of a challenge in clinical syndrome because AML patients often have a lot of things going on that can mimic DS. So a high index of suspicion is incredibly important. The clinical presentation includes fever, respiratory distress. There can be pleural or pericardial effusions. There can be peripheral edema, hypotension, renal dysfunction, weight gain. You can even have pulmonary infiltrates. And as you can tell by the description, the problem is that patients with AML may have lots of these things. You could be worried about pneumonia. You could be worried about tumor lysis. So there are lots of potential clinical confounders, but you have to have a high index of suspicion, especially in the first couple of cycles of use of a menin inhibitor. And basically, as with APL, if you're even thinking differentiation syndrome, you're going to want to jump in with dexamethasone. Usually 10 milligrams IV BID is what is started as sort of standard management. And then you use it until the symptoms resolved and then taper over a period of several days. You can hold the menin inhibitor if DS is very severe, but as with APL, the important part is to try to keep the therapy on board because obviously blowing up the leukemia and getting rid of it is important. So you don't want to stop at the first sign of DS. You just want to manage with steroids, maybe some diuretics. You can use supplemental oxygen if needed, but try to keep the drug on board. Simultaneously, you can work up for other things, pneumonia, sepsis, et cetera, but I'd be quick to start those steroids. The other thing that has to be considered very importantly in the menin inhibitors is QT prolongation. That is something that is part of, I think clinicians know to check EKGs at baseline, but they should be followed. And especially there is a strong signal and a black box warning for revumenib. You want to have a look and continue to monitor the QT, especially in patients who are on multiple confounding agents or potentially interacting agents. And many of these patients are older. They're on lots of different medications that could potentially prolong QT. They also take antiemetics and sometimes antibiotics that can be QT prolonging. So these can gang up on each other, and you want to make sure to follow the cardiogram. Third category that's important is management of drug interactions. Azole antibiotics or antifungals are the ones that immediately get attention. I think clinicians are used to this with venetoclax, but now with menin inhibitors and increasingly with triplet combinations, which may include both venetoclax and menin inhibitors in some scenarios, There needs to be careful monitoring for the need for dose adjustments or reductions. Again, for example, with revumenib, this is going to be needed. Less so with ziftomenib, but still monitoring for multiple drug interactions with your clinical pharmacist would be a good idea. I think that other interactions can also come into play. We want to make sure that we are optimizing for other toxicities. There can be some nausea. There can be GI toxicities that are associated with menin inhibitors. You want to manage those. Also, as the drug interactions pile up again with antibiotics and with other concomitant agents. I think myelosuppression is the most difficult to discern. There doesn't appear to be an extremely strong independent signal from the menin inhibitors, but you do have to watch for cumulative myelosuppression, especially again as the regimens for AML get more complicated. It is difficult to determine sometimes what is being caused by the drug and what is being caused by the disease. So this is why early bone marrow evaluation in the first induction cycle, sometimes as early as day 14, are helpful in documenting blast clearance in AML so that the docs can start understanding when the disease is cleared and when it might be feasible to adjust dose and schedule of the agents that you're using for induction. And that's a whole separate discussion. So menin inhibitors are here to stay. They are providing excellent responses, durable MRD negative responses. They are changing the management of NPM1 and KMT2A rearranged AML. Make sure to look carefully for those diagnoses. Again, mutations for NPM1, rearrangements for KMT2A, VS differentiation syndrome on the top of the list of toxicities. And thank you for your attention.